Good afternoon, everyone, and thank you for joining us today for the EICAL Live. For our session today, EICAL Live, as you all know, it's open forum discussion every 2 weeks where we will post our guests from different institutions. And it's part of the EICAL Congress, Emirates International Congress on Artificial Intelligence and Visionary Leadership in Transforming Healthcare. That will take place on March 28, 29 in Adnig. And I'm reminding everyone that to attend the Congress. So today, our session is about the future of healthcare research, AI evidence and impact. This session focuses on AI as a research studies and discipline in healthcare, how it is studied, validated, and governed and translated into real-world impact. Our discussion is about scientific rigor, evidence generation, and decision-making. We are joined by the experts today, and we are really very honored to have today with us our guest, Dr. Mohammed Yaqub, Chair of the EICAL Congress, and he's Associate Professor of Computer Vision from Mohammed bin Zayed University for Artificial Intelligence in Abu Dhabi. And we have also Dr. Roni Rajan, Vice President, AI and Applied Science in M42 Health, Abu Dhabi. And of course, we have also Dr. Farah Shamout, Assistant Professor of Computer Engineering at New York University, Abu Dhabi in UAE. Thank you for joining us today. It is really our pleasure to have all of you. And I think today's session is really a unique one and very important because when we are talking about healthcare research, we're talking about the future of healthcare. So I want to start by asking a question because I'm sure most of the audience, they really want to know our guests and your background to give them like an idea about all your work. So to set the context and help our audience understand more, I would like each of you to briefly address 3 points. Your primary area of AI research or clinical research leadership in healthcare, and how research decision and approvals are typically made in your institution, and how collaboration and research support across academia and health systems, industry, or regulators currently happen in practice. So I would appreciate Heiko, if you can answer in 2 or 3 minutes. You can start maybe with Dr. Yaqub.
Sure. Thank you very much. And thank you for this exciting event. Mohammed Yaqub, faculty at Mohammed bin Zayed University of Artificial Intelligence. I currently lead a team of 30 plus researchers, all working in AI and healthcare to try to tackle real world problems. I am more into medical imaging, so how to really tackle different problems through developing algorithm that assesses, say, ultrasound, MRI, CT, PET, and so on. Prior to that, I spent about 14-ish years at the University of Oxford, where I did my PhD, and then followed with the research work for about 10 years and industrial work in startup, which is my research. And then that's at some point I decided to go back to academia, and then I went and I decided to come to the UAE for the world first AI university, which is MBZDAI, and which was an exciting opportunity. Now, when it comes to specific research themes I work on neurodegenerative diseases, fetal health. I work on oncology-related problems, and I work on cardiovascular diseases. These are the 4 themes, but the technical component of that is how could you develop AI algorithm that can early detect diseases, accurately diagnose, and tell the future, or in other words, prognosis. That's question number 1, and the question number 2 is about the process. At the university, we're more of like a technical university, so really approving research studies is a simple thing because everything we do is research. But then I collaborate with lots of hospitals in the UAE, and then I go through the process of their approval, and that's it varies from one place to another. Some hospitals were really efficient and really proactive in trying to do AI in healthcare research. I managed to do with them amazing research outcomes in the last 2 to 3 years. Others are probably this lagging behind, but I was trying to catch up with some of these hospitals. So these are the answers to the two questions. The third question, now I forgot it.
How collaboration and research support across academia and health systems, industry or regulators currently happen in practice. So because our audience, they want to know how this process is happening since you start brainstorming the idea of the research and then the approval, and how you were getting the support from academia, from your institution, and the regulatory bodies.
Yeah, the collaboration is the key to succeed in this research project. And the way it works, at least in my perspective, is that I typically have a very large, good connection of clinicians who are excited about solving healthcare problem or improving the way that they look into healthcare problems through AI. And then things start from there. Like we start to discuss, we come up with good ideas. If we do this, we do that, that may lead to better outcomes. And then the collaboration starts from there, from just small ideas to like research project. But you mentioned industry, that's another route to collaboration. So we collaborate with lots of industries, and the way usually it happens is that they have a pain point, we have the talent to solve it, and they talk to us to try to resolve these problems. And from that time, we engage hospitals in the UAE and abroad to try to tackle these problems.
Thank you, Dr. Yaqub. Talking about AI industries, so Dr. Rajan, M42, spoken about the collaboration. Can you please give us introductory about your background, what research you are doing? So same question.
Yeah. Sure. Thanks. First of all, thank you so much for having me here. I am Bons. I am the VP of the AI and Applied Science team at M42. My background is in medicine, so I'm not academic researchers like the rest of my esteemed colleagues. I worked as a general practitioner, as a medical doctor for 8 years before doing my post-graduation in clinical data science and artificial intelligence. I joined the company 6 years ago as a clinical application specialist of the AI team. So that's when I started working with AI specialists and researchers, trying to give the clinical aspect and guidance around the model development and things. Now I lead the team with both the AI research and development under me. And further, if I just talk about the organization, we mainly are divided into 3 main platforms. The first platform, they operate a lot of clinical hospitals, so things like Cleveland Clinic Abu Dhabi, specialty diabetes centers like ICLDC, Moorfields Eye Care Hospital, and so on. Most of the clinical operations. The second vertical is around genomic sequencing and labs. So we operate the Emirati Genome Program and the National Biobank of Abu Dhabi and so on. The third platform develops digital health solutions, things like the Health Information Exchange of Abu Dhabi, Malafi, the Claims Exchange Post Office, Shafafi, and so on. So if you think about it, M42 operates a lot of different types of institutions and entities. And where we come in is to enable the AI R&D. When I talk about AI R&D, it's not core research like universities like NYU or MBZ. It's more around applied research, trying to think about what clinical problem can be solved using AI, and trying to think about how can we prove or gather evidence around the validation, external validation, and population scale validation of these models, and also proving clinical impact of these models. So that's why we mainly focus on. We've had projects around LLMs, around medical imaging, chest X-ray, genomics, also smaller projects, and so on. And we work with different teams within M42 mostly to make this happen. To your point about collaborations, I think most of our projects are internal, so we work with internal entities. So it's more about getting IRB approvals from the institutional review board of M42, and also then DOH approvals. If it comes to working with population scale data, it has to do with active collaboration with the DOH themselves. So it's different for different cases, I would say.
Thank you so much. Thank you. And Dr. Farah, New York University. So do you remember the question? Shall I repeat the question?
I think I remember that. In a few minutes I won't, but I'll try.
Yeah.
So my name is Farah, and I'm an assistant professor of computer engineering. Similar to Muhammad, we also knew each other in a different world, where I was doing my PhD in Oxford, also in biomedical engineering, where I specialize in AI in healthcare. And since then, I moved to Abu Dhabi and I set up my group at NYU Abu Dhabi called the Clinical AI Lab. And there we focus on, similar to what my colleagues also care about, building robust AI models and technologies for real-world clinical problems. And we basically have 4 main research areas. The first one is related to in-hospital clinical decision support. So how can you build AI models that can better identify patients who are high risk, for example, those who are hospitalized or in the ICU. We also work on image detection models, for example, for chest x-rays. And we also have some models for clinical notes. But in the context of in-hospital, we are currently focusing on the integration of all of these models, both in a multimodal approach, but also in a way that could be useful for clinicians. So there's now a lot of hype around agentic AI, but we're also working on that. So we're trying to come up with agentic solutions that can support doctors in the hospital. And then the second team is more oriented to women's health. So we have an ongoing project with a local clinic related to using AI for IVF and optimizing the full workflow. And then the third team also related to large language models, where we're specifically focusing on like the methodological constraints of LLMs when it comes to Arabic-speaking populations. So how can we democratize access to health using LLMs, but also ensure that the models work well in Arabic? Then the last one is more about working with clinicians. So what does the future of work look like with clinicians in the context of AI? So we also have some initiatives in that area. And then in terms of approvals, I think similar to Hamad as well, is in academia, in the nice thing that you have academic freedom to pursue research projects within your domain. So we generally just come up with ideas that would need to solve an existing methodological problem in the context of a wider clinical application. And we also go through IRB approvals. So if we're working with real patient data, even if it's some of the restricted publicly available data sets, we have to apply or be sort of abiding with the ethics related obligations. And we work with hospitals as well in terms of getting their research proposals approved in order to also get the IRB approval. And then the third question was about
collaboration and the process from the regulation body about your, research.
Yeah, so the way we've viewed collaboration so far, I agree that it's crucial for successful projects. I think working with clinicians brings really useful insights about the utility of what we're building, because many times in the context of AI, we're trying to optimize metrics from a methodology point of view, but then we forget about how this model could be used in practice. And I think they're two useful but different goals. So working with clinicians helps us identify what its clinical pathway will flank for certain models.
Do you think healthcare organizations are supporting you with access, when it comes to collaboration with the clinician, or do you have some difficulties in this area?
No, I think we have a lot of support. I think it has changed over time. I think when I first moved here 6 years ago, there was some enthusiasm amongst some individuals, but now I think the culture has completely changed. I think most of the healthcare entities that we engage with are pro-innovation, pro-AI deployment, and they're actually really excited about it. And I'm more on the risk-averse side of things. But yeah, we are lucky to work with amazing clinicians. Can think of a few straight away, and we have co-authored papers with them. They've helped us with data annotation, they've helped us with data access, so we work very closely.
Thank you, Dr. Farah. Actually, it's really amazing to hear all this collaboration and research that's happening, and I'm sure our audience, they will really love to know more about, how all of you are working, ensuring that this is something really gonna really happen in the future and support advancing the healthcare system. So I'm going to come back, of course, to more question about this collaboration and the challenges. But I want to give the floor to Dr. Muhammad Yaqub to lead the scientific discussion and give us more about when it comes to impact and evidence. So please, Dr. Yaqub, please.
Thank you, Ahlam. Thank you for this amazing introduction to everyone. I guess now, ideally, what we want to do is to go a little bit deeper and talk about AI and research, AI in healthcare research. And we've been here for a few years in the country. We've seen things, as you mentioned, transformed over the last 3 years with the advancement of AI. So let me start with the first question, which is start with you, Ronnie. So when we think about AI in healthcare, or actually AI in general, and many people say AI, many people say we know AI and we use AI, and how do you see it? Do you see it as as a tool, or as to help support the daily practice, or as a methodology that actually transform things, or in other words, as a scientific discipline in its own right? So what are your thoughts about AI? And let's make it specific to healthcare.
Yeah, definitely. Thanks, Mohammed. I think when for us answering the question about how things have changed over the past 5-6 years, I was just thinking about why that could be possible, right? I think initially the concept about AI was very foreign to clinicians and the healthcare industry, right? And as of all industries, I think ChatGPT or LLMs have kind of democratized the idea of AI into all domains, right?
Yeah.
So I think when you think about specific AI models or traditional AI models, I always thought of it as a tool because it's just understanding the nuances of the technology, understanding the strengths and the weaknesses, and then deploying it as a tool, right? But with the advent of LLMs, I'm starting to think not just for academic researchers, but also for healthcare workers and clinicians. It's become like a scientific domain of understanding the complete, technology in and out, right? So it's about understanding not just where it works well, but especially where it doesn't work well, right? Understanding the nuances, the ethical constraints, the bias issues, the hallucinations around LLM. So I think as and more the AI literacy around the world and specifically in healthcare workers and clinicians increase, it's becoming more of a scientific domain where people are spending more time to understand in depth how it can influence their clinical workflow, and also how they can help it improve the solutions and so on. That's how I feel about it.
That's great. If I may follow up on that one, because one of the great studies efforts today is on tuberculosis. And what's amazing about it is not, if you look at the AI part of it, I would say it's a great tool, a great methodology, but what's amazing about it is the deployment and the evaluation. Can you elaborate on that and tell us like what it's actually needed to deploy AI at scale and have it reproducible, evaluated properly, not just like I came up with an idea, I tested it, it works, but actually it doesn't work. What you guys did made it work. How did you make it work?
Yeah, absolutely. Thanks for that. Just to give the audience and get some background on the topic. When I said it operates multiple clinical entities, one of the entities it operates is called Capital Health Screening Center. Now, Capital Health Screening Center or CHS, they conduct medical screening for visa applicants. So they get around 500,000 patients or participants coming into the KNFATI, which is around 2,000 cases a day. Part of the medical screening is chest X-ray taken for TB, right? So you have around, 2 or 3 radiologists looking at 2,000 scans a day, which is less than a minute per scan. And when we looked at the volumes, we understood that more than 99% of these cases are normal. So we had extremely trained radiologists sitting all day long, 99% of time they spent on these normal cases that don't add any value to the healthcare operations, right? So that's why I think the way we structured it started with the pain point and not just with a scientific question. It was about what is the clinical pain point at CHSC and can AI be a solution to it, right? So then it started with, okay, let's look at the data. We had enough data with enough diversity, enough volumes and so on. And we figured out we had enough historical data. Then came the scientific approval process of getting IRB approvals, DOH clearance and so on. So that itself took months together, right? Then we got access to the data and then we trained the model thinking about, okay, if we want to diagnose TB, should we just do a TB diagnosis, yes versus no? Then we understood that because, like I said, 99% of cases are normal, a clinical pain point is not the diagnosis of TB, but the overload of the normal volumes. So then we changed the scientific question to, can we automate the reporting of normals and let the clinicians or the radiologists handle things that they are trained to do, right? So they can take care of the abnormals and isolating the TB cases from the abnormals. So, but can the AI automate only the normal reporting? Then the question changed to, okay, can we build a model that's normal versus abnormal? So TB is out of the question, right? When we trained the model, tested it on retrospective data, we realized that during subgroup analysis, a lot of old TB cases were being diagnosed as normal. Why is that? Because clinically, when you look at the chest X-ray, the features of the old TB resembles normal more than active TB because you don't have active, infectious sites. You just have a consolidation, which is very small in an isolated location, right? Then we had to change our methodology away. Instead of doing a binary classification, that is classification into 2 groups, we classified it into 3 groups, which means we went back to the clinicians and re-annotated all these scans, especially the old TB ones, to create 3 classes of normal, abnormal, not TB, and within TB, there's active TB and old TB. And that then improved the performance and the model was able to catch the old TB cases, right? So if you see, like, there's a lot of steps where we involve the clinicians into doing this so that we can make sure there's an actual clinical impact of the study and of the model, and not just optimizing for performance metrics like accuracy and so on. That was until development of the model, right? Then it came to deployment. So the first step of deployment was trying to find out an AI orchestration platform that takes care of integration with EHR records, integration with PACS records, and the smooth workflow, the clinical workflow, without any change for the doctors themselves. So that was the second process where we spent a lot of time trying to identify the right partner for AI orchestration, and then we did that. And then the next study we did was a prospective analysis. So we ran this model at CHSC in a shadow deployment without any automation for 2 years, looking at over 1 million scans, and we published that study in NPPA Digital Medicine. We found that after looking at 1 million scans, our model was able to, get an FNR rate of 0%, which means after looking at 1 million scans, we missed 0 TB cases, while being able to automate up to 80% of the cases, which means when we initiate automation, the doctors will only have to look at 400 cases compared to 2,000 cases that they currently look at.
Yeah.
So when you think about exactly, yeah. And when you think about this, so what we're trying to measure is what is the clinical impact and not the scientific progress or performance of the model, right? We change the equation to see what is the clinical impact, what is the workload reduction of the doctors, while maintaining clinical safety, while maintaining as least false negative rate as possible, which is, I think, the phase 2 that we achieve. Phase 3 will be after automation. We are planning to actually, again, assess the performance pre-automation versus post-automation, look at economic benefits, time saved, result of TET of the reporting, effect on the physician's life, as effect on the patient's life, and so on. So it's multi-step process where we look at retrospective analysis, prospective analysis through shadow deployment, and also post-implementation economic impact and so on.
Thank you very much. It's a fascinating study. Maybe I follow up on this question to you, Farah, because we're both researchers at a university. We don't do this large scale. At least we can, if we get the data, we don't get large scale evaluation like retrospective, prospective. And do you think there's something missing, but especially when it comes to the development of these AI algorithm and the reproducibility of the results? And are we doing it the wrong way in research? What do you think?
I don't think we're doing it the wrong way. I think we're just doing it differently.
Yeah.
Again, from our point of view, maybe we approach it with research questions related to the development of the AI methods that could eventually result with a tool or a technology. And along the way, I think we do answer important questions like related to, for example, how do we best do data integration and cleaning? How do we ensure that the model is not biased? What kind of algorithms do we need to use in order to, for example, account for missing data if we're doing multimodal fusion? So I think maybe we just dig deeper into the methodology rather than the downstream deployment. But I think maybe for that, one solution could be is to have stronger academia and industry partnerships, such that we could also get, and this is common generally, but maybe we just need to strengthen it further, which is to get maybe industry-based use cases and to tackle them from a research point of view, because I think we can generate different insights there. And I think the other thing that if we want to do these kinds of large-scale validation studies, we also need more support generally, like funding for these kinds of projects, because I think the projects that we lead have a different kind of scope compared to running validation studies or clinical trials and so on. And I think we're moving towards that direction, similar to the recent DOH grant or call that is currently open that focuses specifically on clinical trials and real-world validation. So I think there's a push to go towards that direction, and I think we're experiencing it now. And I think in a few years we're going to see more studies related to validation. In our lab in particular, we're currently looking at a few potential validation studies, but more towards Simon perspective validation. So we're trying to see how would some of the models that we've built perform in a real-world setting while assessing performance drift or data distribution shifts. But again, we're looking at it from a research point of view. So I think we're getting there. it's the right time to tackle these kinds of questions. And I think we'd also be very open to industry partnerships similar to the ones that we're working out.
Absolutely. I think one thing to echo on both of you when you said when we try to solve something with AI, it has to have value. We have to listen to clinicians. So for instance, I just want to mention from my perspective, I actually, back in Oxford, both of us, our offices were sort of inside the hospital. I mean, we were 1 minute away from Churchill Hospital and a few minutes from DR Hospital. That's number one. But here in the UAE, we're trying to reproduce this. I mean, it's one of the challenges I can feel here is that we don't have the concept of university hospital yet in Abu Dhabi city. We have it in Al Ain. We don't have it here. That is one limited factor. But still, really going and talking to doctors. On Monday, for instance, I'm going to SSMT to talk to clinicians. We want to hear their pain point. We can't just solve a problem without listening to them. They are the driver for us. Okay, so now, based on that, let me follow up with a question and go to Farah and then come back to you, Ronnie. So it's about, okay, so what constitutes high quality evidence in AI-driven healthcare and clinical research? How do you, when can you trust an AI research in healthcare? Because that's not an easy thing. Like if you do an AI solution in, I don't know, packaging or logistics or finance, there is a room for error. In healthcare, there is no room for error. I mean, there is a room for error everywhere. People make mistakes, but it's a different story, right? It's a much more rigid study. So what do you think about that?
Yeah, that's a great question. I mean, I'm currently thinking a lot about what is the value of what we're building and engaging regulators as well and insurance companies. I think we really need to think about first, in this context, who will the tool benefit, but also who's going to pay for it. I think these are two important questions because if we want to get something to the clinic, we want to make sure that someone's going to support and champion that specific technology. And I think in terms of patient outcomes, I'd say it's really tied to what the use case is. Like, for example, with the IVF project, we're currently thinking a lot about like how would this tool really enhance patient outcomes. If we're just, for one of the models that we've built, for example, we've looked at automating embryo staging because usually embryologists look at the embryo manually and then they check at which stage the embryo is at. And we have an excellent model with extremely high AUC, area under the curve. But then when we think about what is the value of this model, like if we save some time for the embryologist, what would that really mean in practice? It's helping the embryologist in the lab to save time, maybe to do other things or potentially see more patients. But for the patient themselves, ultimately want to improve their success of, for example, pregnancy in this context. So I think for us, value creation in AI brings me back to why I joined this field to begin with, which is to improve patient outcomes. And I'm very focused on this specific objective, and I try to tie it to every single project because it eventually, sure, operational benefits are useful, cost reduction benefits are also useful, but I think AI value creation specifically needs to be linked to patients. And there was a recent report that I also read from a consulting firm that surveyed multiple healthcare institutions about their investments in AI. And many of them are actually making huge investments in AI without fully defining the traditional KPIs of cost reduction and so on, because they can see that there could be something useful beyond that for patients. I think that should be the ultimate priority.
Thank you. Maybe the same question, but from a different angle, because this is something we notice a lot in AI in healthcare. If you're a medical doctor, so if you're trained to do a task, and you say go to a different country, you still can do the same task, even the population is different. Or you've seen an X-ray image from this machine from GE Healthcare, or then next day you saw another one from Philips. You still can read that, right? AI is not good at this. AI doesn't continually learn, doesn't easily generalize, and doesn't, like, this is more about like the point I want to mention, a continuous learning system. These systems are not really easily able to continue learning. So if you change the system a little bit, if you change the acquisition protocol, if you change the doctor, they might fail. So any thoughts on that?
Yeah, absolutely. I think you bring a very important point, right? So as Farah also mentioned, in the end, it's about the impact. So impact depends on where you will finally deploy this, right? So I'll take the example of TB, but also other cases, right? For example, in the example of the TB model that we did, we initially trained a smaller model, but then we also thought about, okay, what if we train a foundation model and, fine tune that for TB, just improve performance. But in the end, a foundation model or a bigger model fine tuned would eventually lead to more operational cost, which might not be effective enough to be deployed in practice, right? So there's a lot of nuances to this. There's a lot of things beyond just the accuracy of the model. One of the things you brought up is exceptionally true, right? So when it comes to making sure this model performs well in practice, you have to make sure that it performs across geographies, across populations. So conductive, thorough subgroup analysis across different subgroups. For example, demographic subgroups of age, gender, nationality, that is extremely important. But beyond that, like you mentioned, also the machine types, the hardware, the locations of different centers. For example, CHAC, though it's a centralized system, they operate, I think, 7 different facilities, and all the images come to a centralized location. So in a subgroup analysis, we didn't notice that different centers have different performance rates, right? So understanding that what is the best model that gives uniform performance across and also stable performance at a cost that's acceptable to the community and creates an impact is essential to check for. And that's why I think when it comes to both model development and model validation, getting access to as much data as possible to conduct such comprehensive analysis becomes very important.
That's good. I think I want to actually have another question, but I'm going to ask a question to both of you, which is, to me, most of the AI in healthcare research is focused on diagnostics, is focused on solving medical problem. Are we doing it wrongly? Because honestly, if you save on operational aspects in healthcare, you could do a lot more. You could save much more. So are we doing it wrong, or probably we're not, or maybe we're probably not doing good enough work on operational aspects in healthcare?
I definitely think operational aspects are a lower hanging fruit because it's lesser regulatory constraint to enable these things. When you think about doing a more diagnostic, if you think about even the TB screening phase, right? Because it is in a non-clinical environment, because it is in visa medical screening, it doesn't really impact healthcare practice or clinical practice or treatment for these patients. They're not technically patients, they're visa applicants. Yeah. So that's why this kind of makes it an operational case. Workload reduction is an operational case, right? So that's why we were able to do it at a much faster pace. But if I had to do a similar TB diagnosis model for the clinical care at a hospital that's running TB diagnosis and screening to treat those patients for TB, that would make it completely different, right? That means I'd have to validate even further or more complicated cases, symptomatic cases. It will change the equation completely. Then comes in the regulatory clearance fact, because right now we already talked about regulatory clearance from a specific committee, that is the Abu Dhabi Public Health Center Visa Screening Committee, which comes under the infectious disease department. But if I go into diagnosis, I'll have to take bigger clearances. Maybe even if I want to deploy it elsewhere, I have to think about global regulatory clearance, FDA, CE markings, and so on, right? Which makes it it takes it to a different level. So I think operational use cases definitely, I think, are better that not many people are looking at, because I think when AI first came into healthcare, big promises were made around diagnostics, because that is the cool aspect of AI, right? Curing cancer and so on. So I think that's where the hype initially came, but I definitely see a lot of impact that is to be made and a lot of focus that should be paid to more operation.
More attention should be paid to operation.
Right, and I just, Dr. Yaqub, to Dr. Because, we are talking about advancing healthcare system. I'm talking about which is operation is part of it. And, all healthcare professionals and community, they need your expertise, because you are the one leading this research and implementing this AI solution in the system. So developing a smart hospital, if you are talking about developing, and advancing, a diagnostic solution to support the clinician and to support the physician. However, we have a huge, challenges today. And we just had EICAL Live last month about how physician and burnout and the clinical staff from lack of proper advanced customized operation systems. So I really hope if we, like the AI researchers, can work on this equally when you are working in developing, solution supporting physician with diagnosis, because this is, I don't want to say I don't want to differentiate between both, but believe me, it's very important. It's maybe even it's number one. You need to do this, fix the system. And then this is what they are really looking for, the physician, the clinician, the administrators, because doing this, you are supporting them, you are cost cutting, you are efficiency, patient experience, which is very important in a hospital, number one. So I hope that AI researchers can really look really equally in doing this.
I agree with you. I think we're paying so much attention to early detection and diagnosis, which was fair, and we should do that. But we should also pay a lot of attention on research and how to improve healthcare from operational perspective.
Exactly. Yeah.
You probably, I don't know if you know, one of the leading cause of death worldwide is medical errors. You can reduce medical errors if you improve operations, if you have proper ways to monitor patients, proper ways to. It's not about diagnostic. It's more about like improving operational aspects that you mentioned. Burnout. This is, if you're tired, you're not gonna do a good job.
Yeah.
Certainly, I completely agree with you.
Yes,
please.
That right. I didn't mention this earlier because there's more early research work that we are trying to conduct. But when we looked at, when we talk to clinicians, when we talk to our, clinicians in all of our network, the number one problem that came out is productivity issues because of burnout with documentation, with, so even when you look at, if you as a patient go to a doctor, right? I think in the 20-minute consultation, they'll spend more than 15 minutes
on the keyboard,
not with the patient. So it's not just a productivity issue, but it's also not just burnout, but also it kind of fractures the connection between a doctor and a patient, right? So doctors are supposed to spend the time with the patient, so the patient feels better about visiting the doctor. Like half of, I think, the cure is psychological when the doctor pays attention. So I think one way we're trying to solve this is through LLMs. We're trying to look at, can LLMs be used for automatically documenting the consultation and introducing ambient scribes instead of having the doctor actually look into it. When you talked about medical errors, that's another thing, right? So first thing is, can we automatically transcribe the entire conversation and convert that to a clinical note? Can we look for errors in the clinical note? Can we look for adherence to corporate or guidelines set up by entities? For example, if it's a diabetic patient and there's a diabetic clinical practice guideline, is the doctor's protocol adhering to those guidelines? So that those kind of things definitely can address a lot of these productivity and error issues, and we are looking into that. I think there has been some early research, especially around ambient scribes, but again, it comes back to the same thing, right? So what is the impact that we are measuring, and is that being calculated or measured in the process of the study?
Absolutely. Thank you. Farah, I want to ask you this question. So where do AI researcher and clinical researchers see the biggest gap between strong AI research and its translation into clinical life? Where's the gap to get things out in a proper research?
I personally think, from our experience of building AI for the past couple of years and now looking at deployment, that the gap has to do with something you mentioned, which is trust. I think if we really want to push for deployment, and there are a few studies that were published recently that showed that if the trust between the clinician and the AI system, and between the patient and the AI system, is secured, then we're going to progress a lot more. So there's this term that was coined in the paper called AI literacy in the context of healthcare, and I think that's extremely important. So it's important for clinicians to understand, not to necessarily build AI solutions. They need to understand how they're built, and to not necessarily understand the numbers behind the AI models, or like it's hard for us to understand what parameters of a neural network mean, but understand for the most part the capabilities of these models and what their shortcomings are. Because I think even if we're really excited about AI, we need to be very careful that AI models can still hallucinate, they can still generate errors, they can still make medical errors. So who would also be liable for situations where a medical error actually propagates through the system? Is it the clinician, the user, or the AI model? And on that note, for example, we have one recent study where we looked at automating medical error detection and correction. So we actually built an agentic solution that can classify 10 different types of errors, like diagnostic errors, prescription errors, and so on, and then even rectify them. And this could be based on reports that were written by clinicians or reports that were generated by LLMs. So having this kind of safety layer, I think, is extremely important because it does build trust between the AI system and the users. And then between the patient and the AI system, the study that I read recently basically created like short e-learning models for patients to understand how to prompt models in the context of general health Q&A. And that led to an improvement in satisfaction and in health outcomes. So I think this is an extremely important gap that needs to be addressed because it can help different stakeholders within the system, both the patients and the clinicians, but also us as researchers in terms of how we develop the systems and make sure that they're suitable for clinical practice.
That's interesting. You mentioned trust because I'm going to tell you a story from my own experience in deploying AI research in healthcare into clinic. Back in the UK, when I did my research at the university, developing AI-driven tools to assess fetal health, every time looking at ultrasound data. And at some point, we wanted to evaluate. So we were working with 4 or 5 hospitals in the UK. I do still remember how some clinicians looked at me when I walk inside the clinic, knowing that this guy came with AI algorithm that could replace us. That's just something I heard. Yeah. Really? This is something I heard. I never wanted to replace someone. This AI tool will augment what you are doing. It will speed up slightly what you're doing, but it will definitely release you from something that you should not be doing. So if you are doing something that's repetitive and any other person can do, why not AI do it for you? Why not AI reduce this time, cut the scanning time from 30 minutes to 20 minutes, give you 10 more minutes to do whatever you want. Maybe talk to the patient more, maybe see things or focus on hard cases. And I saw 2 types of clinicians, one who's excited, yes, let's do it. And one who's saying, this guy again. Seriously, that's trust that's 10 years ago. Things are changing because it's also about awareness and education. We see more trust and more willingness of people to use AI. And we always say it, if you're not going to use AI, you'll be replaced by another person who's going to use AI. AI is not going to replace you as a doctor or as a nurse or whatever position. I think these are all my questions. Amazing. But I want to come back to my co-host to ask more questions. Also look into online questions. So Ahlam, over to you.
Thank you, Dr. Yaqub. It was really amazing discussion. And actually, as you just said about the wrong concept, when it comes to AI, we need really to make sure that physician and, clinical staff, and they understand that it's not about replacement, it's about supporting them in what they are doing, including the operation and taking some of their burden, out. So I really thank you a lot for this deep discussion. But I just want to ask, before we start taking questions from the audience, because I know we have huge numbers of audience waiting, and I'm sure that they want really to start asking you and you get more benefits from this discussion. What are the key ethical and governance challenges that healthcare, AI, and clinical researchers are still facing today? Give me a brief answer the challenge. What are you proposing solution? Yeah, start with Dr. Yaqub.
Very briefly, when I came in here in the 2020, one of the major challenges at that time to get access to healthcare data, anonymous data. I'm not talking anything identifiable. And that, to me, has significantly improved over the years. People are now, as you mentioned, Farah, has more willing to work and collaborate, but still a challenge because we know we are a researcher. We know AI is hungry for data. A doctor could look at a couple of X-ray images or I don't know, MRI scans and get to understand this is a glioblastoma in the brain. That's something a doctor can do from 2-3 scans. They will learn that. AI can't learn from 2 scans, 3 scans. It needs more. So we need more data. So when it comes to getting access to more and more data, it's still not as straightforward as I would love it to be. And one way to do it is to actually create, as we know, we have Malafi now. We need to reach to the point where there is a seamless processes to allow researcher. We're not talking about industry now. That's a slightly different story, but we're talking about researcher to really get access to more and more data, medical data in the country or anywhere in the world. So this is to me still not a fully solved problem. So it still takes me time to get access to data. Yes, I should go through a process, and I would love to go through this process, but I want to make this process as simple as possible. That's to me is one of the major problems still there.
Yeah, Dr. Rory, when you mentioned about, this will, I think, I'm not sure about, because you said if you want like a good, quantity of this data. So, and geographically, because you just discussed this previously if you did, for example, Dr. Yaqub, research in a different country, and you had the chance to have this good, high quality, big, data, and you already have like a model ready. So do you really need, for example, do you want to go to another country where you have difficulties with having access to this data, as you said? So do you really want data from this country as well? Or you can, what you did, you can implement in another,
So briefly, one of the major problems with AI is bias. And there's a problem that it's like if you train to a specific population, there's a good chance that it may not generalize across populations. And I went through this process myself. We trained the models on 500,000 data point, mostly trained from data from the UK. It didn't generalize to population in Asia, for instance. So we had to go and collect data from Asia. So that's 10 years ago. We are now building algorithms that are better, more generalizable, but still what the best way to solve the problem of being fair or giving you accurate models that work across different population, different variables. You should need data from different population. So unfortunately, we still live in this era until we figure out an AI algorithm that is smart enough that can learn from few cases, not necessarily from all population. We're still not there. But once we get there, okay, we don't need that data. But currently, we really need data from diverse population.
Okay, thank you, Dr. Yaqub. Dr. Same question.
Sorry, the question was about ethical concern.
Yes. So the problem or the challenge and solution, what you are proposing.
I think we touched about this once before, right? This concept of clinicians assuming that AI is here to replace us, right? I think that's a question of human autonomy. So basically, one of the concerns is, will a human be included as part of the decision making, right? So I think we need to ensure that we should create systems with human governance, with accountability towards humans who are experts in the process, and definitely with humans in the loop in the decision making process, right? Because that is what is going to take away that uncertainty around. I think most of the uncertainty was developed because initially when AI came into healthcare, a lot of, I think, big names in the business said that radiologists can just stop being trained in the next 10 years and so on, right?
Yeah, and to be honest, not only that, from media now, this is an open dialogue, yeah? And people are watching us. Media, there is this wrong concept. And when you see like big names coming and saying, do not study medicine in 3 years, you don't need to do that. So what I'm expecting when you hear this, from them. So actually it's really challenging. So I really want from all of you, really honestly, to reflect about what they are hearing outside, just to make sure that, again, AI is supporting you. It's not about replacing or not to study medicine in 3 years' time. This is something that really, I think, affecting your work, as you said.
Absolutely. I think Mohammed raised a very valid point, right? It's about enabling doctors to do a better job by replacing the mundane tasks that they do, that they should not be doing in the first place, right? A pathologist shouldn't be spending hours together counting cells, because that's what some of them do. If an AI model can count the cells for them and deliver the score, they can spend their time doing other things. Similar to that, the TB model I just explained, right? Doctors shouldn't be, well-trained radiologists shouldn't be spending their time looking at 1,999 normal cases, right, in a day. They can be actually looking for opportunistic screening of other diseases. So think about that example I said. If we automate most of the normal cases, these radiologists can actually spend their time opportunistically screening for other conditions beyond TB, which expands the scope of the whole program, right? So instead of being just a TB screening program, they can start looking at other conditions. So I feel like AI should be accepted as an augmentation of their work rather than a replacement of what they do, because nothing can replace human technology, especially in an area like healthcare.
I think maybe we need to develop some kind of education awareness series, Dr. Yaqub, about this, so at least medical, community can understand more about your role here. Farah? One problem, one solution in 1 minute.
I think one problem, one solution. I thought of many problems. What there were. Like, maybe is relevant to what Dr. Yaqub mentioned, which is that I think apart from AI, for example, my PhD was focused on early warning models, and these were free AI, like simple threshold-based early warning scores. And unfortunately, there's the ones that were developed in the UK are still being used locally. We did have a study, for example, that shows that by using machine learning models, you can actually get much better performance than relying on models, just simple, again, thresholds that were developed for the UK population due to population differences. So I think that's a governance problem, because it means we already have some legacy systems that rely on other populations, regardless of whether it uses AI or not. And with AI, I think it exacerbates that problem, because we're also building models with more data from other populations and then deploying them here. So I think the solution would be to focus on developing locally relevant models or the local population that work effectively and that are robust enough, because I think these are the models that would eventually lead to the highest value for the patient and for the local health system. And I always go back to the early warning score example, because it's a very simple model that's still being used, and it's leading to a lot of high alarm fatigue. And I think to change that, it's the governance problem, because you need to change how what model is being deployed, but then also how the model is being used, what kind of responses it needs to in the cases of alerts, how do you threshold the model predictions, and so on. I had other thoughts, but
Yeah, because we really want to open the question for the audience. Okay, we have a question. How does the use of AI tools influence publication outcomes in high impact journals?
I can give it a go here. I think thank you for the question. I think the person is referring to the use of AI tools to write and speed up the publication process, because we do use a lot of LLMs now, large language models, to speed up things. Honestly, it's a major problem to me, at least I can say. So I am the general chair of the largest AI in healthcare conference coming to Abu Dhabi in October this year, MICAI. This conference, before LLMs, we used to receive about, say, 2,000 papers, 3,000 papers submission. And each paper is like 10 pages, 8 to 10 pages papers. So it's a large scale conference. And now with the LLMs, we have started to receive triple that. So when you have triple that and the same number of reviewers, it's a major problem. So AI is helpful because it can help you speed up writing, improve writing, make your writing better. But this means also, unfortunately, anyone can write papers now. And it becomes a much more challenging to find enough reviewers to review. We also use LLMs or AI to review. So that's a fact that we stopped using it in some conference. But it's a major problem to me. At the same time, it's a good thing because it's improving the quality of writing. It's not yet improving the quality of research. That's a different thing. So the hypothesis behind the research, the methodology itself, the evaluation, still not there. AI is not good enough to do good improvement on this one. But in the writing, yes, it does help out.
Oh, thank you, Dr. Yaqub. So, any other question? Okay, that's a good one because I think we have many researchers watching us. What is the best advice you can give a beginner in this field? And what do you wish you knew when you started out? I think each one of you should answer this to give advice.
For advice, I would just say, read as much as you can. There's a lot of high quality work and publications that are out there, and there are AI tools that can help you navigate vast amounts of papers and can summarize the papers for you. But I think the best way to learn is to read and potentially also build projects in a practical method so you can understand the ins and outs of the data.
From my perspective, it depends on the person's background. So if you're a clinician, if you're an engineer, if you're, it depends where you're coming from. But in general, definitely utilize the current AI technologies to help improve your learning curve. Learning curve used to be really going, it's very challenging to learn. I mean, especially if you become elder and busy with your work, it's hard to learn. Now with this AI technologies, you can learn faster. You can, especially in healthcare. I now, for instance, I can give an example. I really like to drag a PDF, which could be a paper or a book, into ChatGPT, or I prefer to use Notebook LM, which is one of Google's tools, and I just chat with it while driving. I chat with ChatGPT. Oh, okay, here's a paper I'm uploading. Tell me about it, and then it tells me something. So if we live in a very busy environment, all of us are busy. All of us are doing much more the work than we used to do maybe a few years back, and hence this probably will prevent us from learning. And we should never stop learning. And we should utilize AI to learn in whatever we can do. And one advice, yes, use ChatGPT or one of these models to learn. Make them talk to you. This is your assistant. Challenge with some question. Make them make you learn in a simple way.
And just because Mohammed mentioned, I don't know if, the background of the patient, if they're clinicians. I mean, coming from a clinician who went into AI, I would say step out of your comfort zone. I think more clinicians need to understand this, Chris, because AI is coming into healthcare with, as much with a vengeance, I would say, right? So clinicians need to understand the technology, the strengths, and especially the weaknesses, and they need to step out of their comfort zone to learn something out of the medical domain, because they will become essential and critical parts of making that decision using AI in their workflows.
Thank you. Any other question? How close are we to achieving artificial general intelligence, AGI, and what are the biggest remaining hardness? Yeah.
Sorry. I mean, I don't know if people know, like car companies, they were talking about having an autonomous driving car from 1960. They said in 20 years, 1960, they will have an autonomous car. We're in 2026 now, we don't have an autonomous car driving everywhere. I don't know if we're going to reach AGI. I mean, you'll find some people, this is like, honestly, my own perspective, not just, other people will disagree with me, I'm sure. I don't think we're going to reach AGI. I don't think we're going to reach that at all. We will reach to the degree where we have very specialized, not very special, a bit more general solutions that can solve a problem. So I'll have an AI robot that's running through my house and cleaning everything in my house. Not just the carpet, because we have that, but everything. Okay, that will work. But having that robot to do, for instance, everything I or anyone else does, I don't think we're going to reach that. That's my opinion.
Well, thank you, Dr. Yaqub, for being honest. Okay, I think this might be the last question, Hussein. Okay, 2 questions? No, I think we'll take only one. How do academic researchers plan to bridge the implementation gap, since building AI is different from making it operational, especially in the UAE? Big one. Yeah. So,
government, everything, collaboration. We have to open corridors between us, say, okay, you know what, we want to do this.
I think go ahead. I think this is really the reason behind the establishment of the EICAL Congress, to be honest. I mean, it's the reason is bringing everyone under one umbrella, the AI researchers, academic researchers, healthcare organization, AI industry, where they will really start to collaborate. And this is one of the reasons why we do this bi-weekly, the EICAL Live, because that open dialogue where each parties, they will discuss and see how they can move this forward. So as you said, Dr. Yaqub, collaboration, and this is, believe me, I mean, I'm not sure that we can achieve anything if there is no really open dialogue, communication, cooperation between all these organizations. Because you need the hospital to do your research. correct? You need the access. We need the regulatory bodies to give you all these approvals, you know. And you need physicians to make sure that they are supporting you because you want to support them. Yeah. So, yeah, I think this is just
On the issues, apart, in addition to collaboration, I think another thing we need is like clear translation pathways for technology, for from academia to industry. Because it's true that we can collaborate and come up with great ideas and great solutions, but I think we also need like sponsored mechanisms in order to push these technologies beyond the clinic. Because personally, I'm building a research solution. I'm not building a product. I'd rather have someone come take the sort of made technology and build the product out of it and then make it operational, improve it, enhance it, collect user feedback. Because I think these are two different sorts of objectives. So I think collaboration, but also with industry and government to push the rain in that reason.
yeah. Do you want to add anything, Dr. Daniel?
I think, I agree with both points, right? It's more about establishing the framework and the platform to enable research. That can be through processes, through technology, through platforms, whatever it is. But to enable better collaboration of multiple institutions that come together to solve one problem.
Yeah. Shall we take another question, Dr. Yaqub? What do you think?
Last question.
Okay, let's see this. Should negative results in AI research be published more openly, and why aren't they? A challenging one.
Before we refer to negatives, apologies. If you want to go ahead first, please go ahead.
Yeah, I think about negative and first concept, like what does it work?
Yeah.
I think it should be published. Absolutely. There are publications in this area.
Absolutely.
We just had the paper submitted about how these models are miscalibrated and shouldn't be used when they're miscalibrated. And I think that's a negative points of view regarding AI, and they should be published. Yes.
But you feel this kind of publication, like negative results, may affect your future, or the physician trust something. No, not really.
I don't think so, because I think it will flag what people need to work a more complete rather than blindly trust the model as it is.
Again, we refer to the word negative. If we really mean negative, means something that we tried and it didn't work in research. Yes, it should be published. We published a paper in 2023 about there was lots of research from many top universities looking into how could you predict MGMT promoters from structural MRI. This is something that you have to do DNA test to do, but could MRI scan at structural MRI predict that? Can AI look at the structural MRI and say this is MGMT on or off? And that's very important for chemotherapy for a specific patient to say whether I should give this chemotherapy or not. And there was lots of research in doing, it works. Some people were saying it works with a high degree of accuracy, and some said no. We did a thorough study to say actually this doesn't work. You cannot predict. We tried every single AI algorithm we can think of. We cannot predict MGMT promoters from structural MRI. If we didn't publish that paper, it was published in a top journal in my domain. If we didn't publish that, other people would have not known that actually we should not rely on this research or that research. So we negated some research articles that said they can solve it.
Thank you, Dr. Yaqub. I think we should really stop taking questions because of the time. But it was really amazing discussion. I really thank you a lot for coming. It was really important for our audience to hear all this about research, about where are we going with this, about how we can support them. And thank you so much, really. And we're looking forward to this research session in the EICAL Congress, which is in that second day.
Yes.
Led by Dr. Shahrukh Hashmi. And which he couldn't make it today because of unexpected, really, commitment and reasons. So we really thank him for all his efforts as well, behind the scene. So do you want to say anything, Dr. Yaqub, before we?
No, sure. Thank you very much for joining us, everyone here. Thank you, Farah. Thank you, Ani. Thank you for joining us. Thank you, Ahlam, for moderating this, and the team behind the cameras and all the effort. We look forward to meeting you in March, 28th and 29th of March. Please come and talk to us. We are excited.
Yes, exactly. Yeah. Thank you so much. Thank you.
Thank you.